Welcome back to I'm Journal Club. After a hiatus over the summer, we are filming again. Our topic today is very familiar to those of you who work in the hospital, DVT Prophylaxis. There's a new meta-analysis. Will this change everything? Our guest today couldn't be more suited to discuss this. Dr. Anthony Breu is an academic hospitalist at the VA in Boston. Let's jump right in. Dr. Breu, thank you so much for joining us today.
Oh, my pleasure.
So before we start today's talk, I just wanted to make two quick plugs. One for your latest tutorial. So for those viewers or listeners who haven't been inducted yet, a tutorial is a series of tweets that form a tutorial, and the latest one was on the kappa over lambda ratio in end-stage renal disease. And the other is your podcast, which is called the Clinicians. And we'll put both links in the show notes. So just bearing the name of your podcast in mind, the one that you co-host, I wanted to start by asking you, why should clinicians be curious?
There's an infinite number of reasons, but I'll offer just a couple. The first is that by being curious, you're going to find answers to clinical questions that'll maybe help you provide better care. So, for example, Ben, you mentioned a tutorial I wrote yesterday about the kappa lambda ratio in normal renal function and in end-stage renal disease. And having a deeper understanding of why it changes over time may actually make me more able to diagnose a patient with a plasma cell dyscrasia in the future. And the only reason I looked up the answer is because I was curious about it. And I was interested in it. Wasn't enough to know a fact. I wanted to know the why. But I think the second reason we need to be curious, among many, is that curiosity will allow us to ask the appropriate questions of our patients and not ask a singular question and get an answer, oh, the chest pain started yesterday, but maybe ask the follow-up question, well, what were you doing yesterday? And so it really can provide us the tools we need to acquire the information, not just from the medical literature and from science, but also from the patients that we care for.
So that's something you want to stimulate in your trainees?
Yeah, and not just trainees, all the people around me.
Mm-hmm. Great. So let's switch gears and talk about today's study. The topic is prophylaxis against deep vein thrombosis, and the paper is a systematic review with a meta-analysis published by Egg and colleagues in a May issue of the VMJ, and we'll put a link in the show notes. So to summarize the methodology, it's a systematic review with a network meta-analysis. That's the type of meta-analysis where you incorporate both indirect and direct comparisons and create a network of studies and basically end up using more data. So the population were all patients admitted to hospitals with acute illnesses, so no elective surgeries, but everything else. And the active treatments were the low molecular weight heparins, enoxaparin, dalteparin, and so forth, unfractionated heparin, all classified in a low and an intermediate dose, and then DOACs, both oral DOACs and also a direct 10 inhibitor, fondaparinol. So there's two comparators, a placebo, and then because not all trials were placebo-controlled, and no DVT prophylaxis, so neither chemo nor mechanical prophylaxis, it sounds like. So my first question about the study, do you think it's ever appropriate not to use a placebo control group, maybe in a real world setting when you look at effectiveness and efficacy is already known and you just want to quantify the effect in a patient group or patient groups that you actually intend to use it in?
So for this specific treatment of chemo prophylaxis for VTE, right? So DVT and pulmonary embolism, could we get away with doing a placebo-controlled trial now? I think the answer is yes, but it would have to be a low-risk population because there's currently no data available, no good data that I'm aware of, for patients who are hospitalized with an acute medical condition, but who are deemed to be low risk for VTE. So in all the key placebo-controlled trials from the 90s and 2000s that looked at this question, they included patients deemed high risk for VTE due to their medical illness. Now, I'll tell you, we in practice prescribe chemoprophylaxis to patients across risk groups based on the benefit profile of patients who are deemed high risk. So I think we could do that trial because I think there's equipoise as to whether or not there's benefit in low risk patients. I think it'd be a harder sell to do a placebo-controlled trial in high risk patients. Those we may talk about, there are problems with some of the original trials in terms of the outcomes they included.
Perfect segue to the endpoint studied here. So in this meta-analysis, they looked at mortality. They looked at symptomatic VTE, venous thromboembolism, and then they looked at some safety endpoints. What do you make of this choice of endpoints in this meta-analysis?
So I'm really pleased that they selected symptomatic DVT and PE because I alluded to the problematic nature of some of the original placebo-controlled trials, right? There are 3 key placebo-controlled trials, again, from the 90s and 2000s, the first one being Mednox. And the problem with these trials is they included PE, they included symptomatic DVT, but they also all included asymptomatic DVT. And the benefits seen in all 3 of these trials was really driven largely by a reduction in asymptomatic DVT. And Ben, I suspect you, and certainly I, and I think most others, don't go around on hospital day 5, 6, and do an ultrasound on every patient looking for an asymptomatic DVT. And in fact, most asymptomatic DVTs don't progress to symptomatic DVT or PE. So there's real questions as to whether or not that outcome is a acceptable outcome to determine whether or not we provide this therapy to everyone. So this study specifically removed those patients. And I believe if they couldn't ascertain whether or not the patient had symptomatic or asymptomatic DVT based on the methods, they just removed all DVTs. And so this really isolates, is there a benefit for PE and for symptomatic DVT? I think the 2 key VTE events that we would care about. So I would say thumbs up for the methods on that score.
Mm-hmm. In terms of the results for the efficacy endpoints, it looks like only some of the groups reached statistical significance. They used a Bayesian method to calculate credible intervals, which is basically the Bayesian version of confidence intervals in the forest plots. So for DVT-PE in the placebo control, only low molecular weight heparins at an intermediate dose reached statistical significance. None of the treatments lowered mortality. Noting that these confidence or credible intervals are very large, do you believe these results that they found? Do you think that the patient population might be too heterogeneous and that might explain the wide confidence intervals and we need more focused studies?
Well, I think the findings for enoxaparin are consistent with other meta-analyses and are consistent with the fact that we have in many ways the best data for that class of agents, enoxaparin probably being the most commonly used. For fondaparinux, we just don't have that many studies. And so you could look at the point estimate and say, oh, this is the best of the 4 classes of agents, right? But I think that would be premature. We just don't have nearly as many studies. I think it's certainly an acceptable option, and that there are hospitals that practice that where that was the standard treatment for chemoprophylaxis. And then for sub-Q heparin, I think this is also consistent with prior meta-analyses and frankly, the fact that that agent, meaning sub-Q heparin, either BID or TID, the studies in which it was tested are a lot older and have a little bit more shaky methodology in terms of the way they did randomization, for example. And then the DOACs, their risk-benefit ratio for this specific indication, I think so far has been underwhelming. I was expecting to maybe find a little bit more of a benefit here with the doses used, but we're just not seeing it yet. I think this kind of affirms a lot of what we've seen previously in terms of the best available evidence for enoxaparin, and probably should be the standard of care for most patients who do receive chemoprophylaxis.
Yeah, and then on the flip side, unfortunately, heparin and DOR also had the highest risk for bleeding. So there's all sorts of side effects that you also wrote about, not just including bleeding, also heparin-induced thrombocytopenia, and then the patient experience basically getting shots every day, often without even being explained why exactly.
Yeah, I mean, I would love to have seen DOACs sort of move up and have a better risk-benefit profile, because the ability to not require subcutaneous injections would just be marvelous. But if you're going to choose an agent that you have to inject, it's much more patient and nurse-centered to do enoxaparin, which is once daily, versus unfractionated heparin, which again is either twice or 3 times daily, depending on where you work.
You wrote an important article in the Journal for Hospital Medicine for the Things We Do for No Reason series, which I believe you also co-edit. So with this meta-analysis, is the score now settled? Is chemoprophylaxis acceptable for everybody again, or do we need more tangential data? Do we need more focus data?
So I don't know that we need more data. I think we have enough data to say a few things. One, when compared to placebo, the agents that this meta-analysis supports, so enoxaparin and fonterinox, or low molecular weight heparins more generally in fonterinox, they reduce the risk of VTE events. The biggest one is asymptomatic DVT, but as I've said, let's put that aside. I think this meta-analysis and other meta-analysis support the claim that they also reduce the more specific event of pulmonary embolism, I would say the more important of the 2 VTE events. Now, what's unaddressed in this particular meta-analysis, and I think is important, something that I highlight in the paper we wrote in the Journal of Hospital Medicine, is the magnitude of benefit is low. So the event rates for symptomatic PE, we'll use that as an example, is low. It's less than 1%. And so even if we reduce it by a decent amount, the absolute magnitude of benefit, stated in a way, the absolute risk reduction is low. And so you'll see in these meta-analyses, number needed to treat in the order of many, many hundred, sometimes more than 500 or 700. So I'll sometimes say to residents, it's quite likely that you go through all of your internal medicine residency and never prevent 1 PE with DVT chemoprophylaxis. Does that mean we should not give it? I don't know. I think for high-risk patients, I still give it. And I would say the risk-benefit ratio does overall favor giving it. But because the benefit is so small in absolute numbers for high-risk patients, and we have no data supporting it for low-risk patients, I strongly believe we should not give it to low-risk patients. And so, Ben, you said, should we just give it to everyone? Absolutely no. We should actually either use Gestalt if you're comfortable with it, or some kind of a risk stratification tool to determine who ought to get it.
There was going to be one next question. So these high-risk groups include patients who have had a prior VTE, who might have other thrombotic events, for example, ACS, maybe certain infections, cancer, maybe a few other conditions. There's also risk scores. Is there a particular risk group that you think of beyond these? Is there a particular score you recommend? Should people just go by what's included in their EHR system, if at all?
Yeah, I think the easiest thing to do is to go with what you have embedded in your EHR, and hopefully you have something. If you don't, I would recommend just using any of the available ones. There's at least 2 or 3 that have been externally validated, and that I would say are generally reliable. But that is better than just saying, oh, they're an acutely hospitalized patient, and therefore they're high risk, and you give it to them. That I think we want to avoid. And this study, doesn't necessarily answer that question because it doesn't include low risk patients. But it does provide additional evidence that if you make the right choice of agent, you can reduce VTE events.
So not taking together this question of whether we should do another placebo-controlled trial in a more focused group versus we know it probably works in this overall group, and it probably works better, but we want to know exactly how good it works in high-risk groups. Do you think it would be acceptable to do maybe a prospective observational study to look at the real-world effect of all of these treatments, or maybe just certain ones in high-risk patients?
So we have that data already. We have population level data looking at hospital centers that are really good at giving chemoprophylaxis, less good, and really, really bad, right? Just based on the rates. And then they try to control for patient level factors, though obviously they can't do it perfectly.
Mm-hmm.
And interestingly, and unfortunately, the benefit for VTE prophylaxis, even in high-risk patients, in these studies doesn't show much there, right? So stated another way, the patients that have really low rates of chemoprophylaxis do just as well in quote unquote preventing VTE as the hospitals that have really high rates. So that data is already available to some extent. So I don't know that we need to do that study again, unless someone identifies a flaw with what has already been done.
Yeah, I believe there's a lot of data out of Michigan. Is that correct?
That's right. That's right. They've done a lot of work on this.
So what would you believe is an appropriate cutoff to use chemoprophylaxis in terms of absolute risk reduction or number needed to treat?
I don't know that I can give an answer that applies to everybody. There are some scoring systems. If you look at, for example, the CHAS-VAS score, right? If you did a study, for example, where you said you randomized people to take a survey and they have two options. Option one is they are given the CHAS-VAS score and they're asked, would you administer a DOAC to this patient? And the other group is randomly assigned just the actual number. So 3% risk, annual risk of a embolic event. Would you give a DOAC? My guess is you're going to get different answers to those two trials. And so what we often do is we just follow the guidance of guidelines or of these scoring systems and don't necessarily say to ourselves, well, is a 50% absolute risk reduction from 2%, is that good enough? And part of the reason for that is I think there is variability in how people would answer that question. And so for me, I don't know that my opinion as to whether or not a number needed to treat of 500 is a good enough bet or a bad enough bet. I think individuals can answer that differently.
Yeah.
I am less enthused about it than most, but that doesn't mean that, Ben being excited about it is better or worse than my opinion.
Yeah, understood. This is a more of an individual decision by the patient and their doctor or their provider, and we might also have lower numbers needed to treat if we look only at symptomatic VTE cases. So that would be something interesting to calculate and to make people aware of. Is there like another message you want to give to people about DVT prophylaxis, having looked at this for so long?
What I'll often say to people when I teach about this topic is, in patients who do have a VTE event during or after a hospitalization, it's more likely than not that that event had nothing to do with whether they got VTE prophylaxis. So there's, I think, a lot of guilt and shame and frankly blame when a VTE event occurs during or soon after hospitalization. One of the first things that's done is we look to see, well, were they getting enoxaparin? And I want people to realize that let's imagine a patient had an event and they were not getting the enoxaparin. I think there's good data suggesting that event was just as likely whether or not they got the drug or not. Most in-hospital events for VTE occur in patients who are receiving prophylaxis. So there's people feel shame, people feel guilt, and people are blamed. But I think a key message is to sort of pause a little bit before, particularly blaming other people. It's hard to tell people not to feel shame and feel guilt, but I would hope that that's mitigated a little bit.
So final question, should then recommendations by the Joint Commission in terms of DVT prophylaxis be changed? Do hospital policies need to be changed? Do we need to do more academic detailing in the sector? And also the guidelines, they don't just seem to align. It's such an interdisciplinary topic so that it concerns multiple societies. Does this all need to be updated and maybe streamlined a little bit more?
Yeah, it's a good question, and I don't have a fully formed answer, particularly to whether or not the Joint Commission should change their standards. If this is baked into an EHR and a recommendation that is to be trusted is offered, then it doesn't take as much time or mental energy. I will say that people often ignore the guidance. It'll say, oh, this patient's low risk, and they'll say, I don't know, let me just give it to them anyway. So I don't know. I think hospital-associated VTE, when you look nationally or internationally, is a huge issue. And even if the number needed to treat is really high, in aggregate, this event still happens, and we can still prevent many of them nationally if you believe it works, and it probably does. So I'm gonna sort of unfortunately punt that question because I don't have a good answer yet. And I don't know. If you put me on a committee, I'd probably let's just play that game. You put me on a committee and I had power, I'd probably say it shouldn't be a part of hospital level metrics. But if by having it as a hospital level metric, people think about it a little bit more, there may be some value there. So how's that for a non-answer?
I think it's the perfect answer to end this fascinating conversation. Thank you so much, Dr. Breu.
Oh, my pleasure.
Here are 3 takeaways from our conversation with Dr. Tony Breu. First, he really liked the endpoint symptomatic VTEs in this meta-analysis. Second, he was unhappy that DORTs didn't do better because the patient experience of getting 1 subcutaneous injection a day or more is suboptimal. And third, regarding whether DVT prophylaxis still makes sense, the answer probably lies somewhere in the middle. Use Gestalt or Stratify, and use DVT prophylaxis in higher risk patients only. Thank you for watching this episode of I Am Journal Club. Please subscribe to our YouTube channel. We will also be coming out with a podcast. See you in the next one.